In this session, we're going to discuss communication and counseling, specifically as it relates to your role in working with ostomy patients. Now, we've already laid the framework for this discussion when we talked about rehabilitative care for ostomy patients. So we're not going to be discussing specifics of what to say. We're going to be talking about things we can do to improve our communication skill, to improve our ability to truly hear the patient, and to be helpful in interacting with the patient. So first of all, why is it so hard? We've been communicating all of our lives. We've been talking since we were probably less than 2, and even before we were talking, we were communicating non-verbally. But communication is not easy. It's a two-way process. I have a message, I have an idea that I want to share with you, to convey to you. I have to decide how to package that idea, that message, what words I'm going to use, how I'm going to share it with you. The way I present that message will be impacted by many things: my understanding, my level of clarity about my concerns and issues, my vocabulary, my mood, all of those things. So then I send the message to you, and essentially you have to interpret the message and try to decide exactly what is it I'm saying to you. And your ability to accurately interpret the message is going to be influenced by a number of things as well. Your language level, vocabulary level, your understanding of the terms that I used. If I use terms you don't understand, you may just gloss over that section because you don't want to ask me. It's also going to be influenced by our relationship. What you think about me is going to be influenced by your own emotional state. The bottom line is, many times, what I mean to say is not what you hear. The level of difficulty, I think, is best manifest by things that happen all the time in our close relationships. You think about your significant other, if you're in a committed relationship. You think about your communication with family, with close friends. And how many of you have either said, or someone has said to you, "You weren't listening, that's not what I said at all"? I am betting that every one of you have either said that or you have heard that. So what does that tell us? Even when we're communicating with people we trust and who trust us, who speak our language and we speak theirs, it's still very difficult. Communication is tough. So that means we have to work at it. And when you think about our role, our entire day is spent communicating. We're listening to patients, we're explaining things to patients, we're teaching patients, we're counseling patients, we're interacting with staff. Every one of those activities requires skill and communication. So we think that if we had to pick one skill set that was essential to success in the specialty nurse role, the wound care nurse role, ostomy nurse role, WOC nurse role, we would pick communication skills. So let's talk about types of communication. There's 2 major types, verbal and nonverbal. The advantage of verbal communication is that you have more control. Most of the time you decide what you're going to say. Although I'm sure we have all had episodes when something came out of our mouths, we blurted something out, and then we're thinking, I did not mean to say that, I wish I could take that back. But most of the time, especially in a professional arena, most of the time we decide what to say. So that gives us more control over verbal communication. However, even verbal communication is frequently subject to misinterpretation because of language differences or vocabulary differences. Language differences, an obvious challenge. Almost all of you will end up in a situation where you're teaching a patient and a family who do not speak your language. They speak another language, and you're having to teach through a translator, an interpreter. That's very difficult because you have to decide, how am I going to say this? You're trying to evaluate, did the interpreter, the translator, really understand? Then they turn around and say it to the patient. at each level, you can have misunderstandings. So anytime that you're teaching a patient who does not speak your language, a tremendous challenge, critically important to frequently stop and say, I know this is very difficult for you because I don't speak your language. I wish I did. So I want to make sure I'm being clear to you. Could you tell me through the interpreter, could you tell me what you heard me say? Could you tell me what you understood out of my explanation? But even when you're talking to patients who do speak your language, you may find that there are vocabulary differences. Every little subculture, every little subgroup has their own language. And I'm going to share a couple of funny examples, and I'm sure you have many examples yourself. I was once working in the VA, and I was there actually as a student. I was taking care of a patient in a 4-bed unit. And the patient next to my patient said, "Hey, nurse, nurse." So I went over and I said, "Yes, sir, can I help you?" Yeah, give me my duck." So I'm thinking, oh my goodness, he's disoriented. So I look at his name tag on the bed and I reorient him. And he becomes very agitated. And he's like, "I don't know what's wrong with you. I know where I am. I know who I am. I just want my duck. Now give me my duck." Oh, wow, that didn't work. So I'm going to try it again. So I tried again using different words to reorient him. Now he's very agitated. And he's like, "Look, nurse, I don't know who you are, and I don't know what your problem is, but if you don't give me my damn duck right now, I am going to piss in the trash can." I'm like, oh my goodness, he wants his urinal. So I gave him his urinal. He's like, "Thank you." Then I went out to the desk and I said to the nurses, "You know that guy in 204? And they're like, "Yeah." I'm like, "You know what he calls a urinal?" And they're like, "No, what?" And I said, "A duck." And they turned, every nurse in the nurses station turned to me and said, "It is a duck." Well, it turns out that is the designation for urinal in the VA system. Everyone calls them ducks. So I was the one speaking the wrong language. The other one I'll tell you relates to being from the South. In the South, older women frequently refer to their vaginas as their purses. So one of my friends was working in the GYN clinic at our city county hospital, and they had a lady come in, and the physician did the history, and then he said to the patient, "I'm going to step out and the nurse is going to get you ready for your examination, then I'll be right back in." She's like, "Okay, but before you go, I just have one question." He's like, "Sure, anything." She's like, "You're not going to look in my purse, are you?" And he's like, "Of course not," because he's thinking handbag. But of course, he goes out, comes back in, and what does he do? Looks in her purse. So we have to be careful with vocabulary, even when the patient speaks our primary language. I think if we're constantly watching the patient and asking for feedback, we will typically pick up on any misunderstandings. Nonverbal is the most critical element of communication. 2/3 of communication is nonverbal, and it's how we communicate feelings. Nonverbal has a tremendous impact on our verbal communication. I can control my words. Can I control my body language? Can I control my facial expression? Can I control my tone of voice? Can I control gestures as effectively as I can control my words? Usually not. So if I say, "I'm not angry," I don't know how many times I have to tell you, "I'm not angry," okay? Okay, what message did you get? I say I'm not angry, I'm clearly angry. So our take-home message is we need to pay a lot of attention to our patient's nonverbals. If the patient says, "I'm fine," but they've clearly been crying and they're very subdued, they have the covers up to their chin, they have the lights off, what's your interpretation? That patient's upset, that patient's sad, that patient's depressed. So pay attention to your patient's nonverbals, pay attention to nonverbals from staff, and try to monitor your own nonverbal communication. The one thing I wanted to mention specifically related to nonverbal is touch and eye contact. Those are two forms of nonverbal communication that are very frequently subject to misinterpretation. In our culture, we expect people to make eye contact when we're communicating with them. And we tend to make judgments if they don't make eye contact. We make judgments that they're not comfortable with that subject or whatever. But in other cultures, eye contact is considered a very intimate, even invasive form of communication. And it's limited to specific relationships. It's considered inappropriate in other relationships. Rule of thumb, follow the patient's lead. If he or she is avoiding eye contact, it really doesn't matter why. It tells you they're not comfortable with eye contact, and so you're going to minimize eye contact. The other is touch. A lot of nurses are touchy-feely, and so we frequently reach out to patients. But some of you are not touchy-feely, and you can attest to the fact that unwanted touch can feel like an invasion of your personal space. So again, watch your patient's response. Touch can be powerful, but if I reach out to a patient and that patient shrinks back, I know that patient's not comfortable with touch, and I'm going to modify my interactions accordingly. Now, our goal always is to make sure we're as clear as possible in everything we say to patients. We want our explanations to be clear. We want our demonstrations to be clear. We want to clearly express our empathy. We want the patient to know that we hear them. But every day, we face multiple barriers in communicating effectively. So I want to just take a few minutes to review the common barriers that we have to overcome to communicate effectively with our patients and with our staff. Communication takes energy and sometimes takes a lot of focus. So let's look at environmental barriers first. Those of you in acute care, you know you go in to teach a patient, well, how many interruptions are there? How many other people come to the room? Whether you're in acute care or home care, if the television's on, that's a barrier, it's a disruption. What about cell phones? What about beepers? All of those things can be distractions and can interrupt trains of thought. So you want to try to shut those down, minimize those, because we've already said our patients are very stressed. It's very hard for them to learn what they need to know because of the level of physical and psychological stress they're under. So we want to make it as easy as possible. When I come in to work with a patient, I'm going to say, is it okay if we turn off the television? I'm going to put my beeper or my phone on vibrate so it doesn't make noise. In acute care, I might hang a little sign on the door that says WOC nurse en route. Please do not interrupt. Well, that doesn't mean anything to the average layperson, so I haven't violated the patient's privacy, but it certainly alerts the staff that either pouch change is going on, teaching's going on, and to come back. So do everything you can to minimize interruptions and distractions. Lack of privacy can be a huge barrier, especially when you're talking about sensitive subjects, and most of the time when we're talking to ostomy patients, we're talking about sensitive material. In some agencies, they still have semi-private rooms. So you might have to think about, is this something you want to discuss now, or do you want to discuss it when the patient comes back to clinic and you can have privacy? Or you might think, is the patient well enough to walk down to a conference room? Can you hold this discussion somewhere else? I remember once when I was trying to give the illusion of privacy and I was sitting close to the patient, keeping my voice as low as possible, but validating that she could still hear me because I'm about to walk her through a pouch change. And all of a sudden the patient on the other side of the room pulls up the curtain and says, mind if I watch? To say I was speechless is an understatement. And then the patient's like, oh, I told Mary, she and I have been talking back and forth. I told her she could watch. I'm like, okay, saved by the patient, because I hardly knew what to say. But most of the time, you want to create a private environment for sensitive discussions in any way possible. So think about taking the patient elsewhere. Think about delaying the discussion until you can be in a private environment. Particularly critical when you're talking about sexual issues, which we're going to be talking about a little later. Finally, time can be a barrier. If a patient brings up a sensitive issue, for example, if the patient wants to talk about their prognosis, if they want to talk about their pathology report, if they want to talk about the fact that their family's having a very hard time dealing with the cancer diagnosis or whatever, that's not a discussion you want to rush. So if the patient brings it up and you know you have practically no time, that you have to be in a meeting in 10 minutes or whatever, it's much better to set up another time for that discussion. It's much better for me to say to you, I'm so glad you brought that up. That's something I really wanted to talk to you about, and that's a really, really important discussion. I can see why it's weighing heavily on your mind. Here's my problem. I have to be in a meeting in just a few minutes, and I want us to have time to kind of hash this out. So would it be okay with you if we put this tops on our agenda for tomorrow morning? The patient usually doesn't have to talk about it now. They need to know they will have an opportunity to talk about it. What about communication barriers themselves? The patient with aphasia, the patient who has a speech difficulty, the patient with hearing loss. We've already talked about strategies for dealing with hearing loss. That's another whole set of issues. So if the patient has aphasia, I have to determine, is it receptive and expressive? Is it expressive only and the patient can understand what I'm saying to him, her? Again, checking back frequently with the patient when there's any kind of communication barrier. Did you understand? Can you tell me what you heard? Or if the patient has expressive aphasia but is able to use like a chart to point out their questions so that they can point to letters or whatever, working with that individual patient to make sure that he or she understands. Sometimes they'll have a family member who understands them very well and who can say, here's what she wants to know, here's what he wants to know, or yes, I think she understands. Emotional, physical barriers, I think we're usually pretty good about attending to these. If we go in to teach a patient, the patient's in a lot of pain, I think most of us realize, I can't teach that patient now. I need to get that patient medication and I need to come back. Same thing if the patient's very fatigued. Same thing if the patient is nauseous. Same thing if the patient's very worried about a specific event. For example, if I go in to teach a patient at 2 o'clock and they're expecting their physician to come in at 3 o'clock with their pathology report, I may not be able to teach them at all. We might need to spend time talking about their concerns and about the what ifs. What if the pathology report says this? What if it says that? Finally, embarrassment. I think we have to talk about this. Patients are frequently embarrassed because they've had a change in elimination, they've lost their standard control over elimination. When you're taking off the pouch, when you're providing stoma care, many times the stoma becomes active. And that can be embarrassing for the patient because they feel like they're going to the bathroom in front of you. And that's not acceptable in our culture. So a lot of times they'll say, oh, I'm so sorry, I'm so sorry, I'm so embarrassed. You want to find a way to make it okay. And how you do that will be different for each of you because you all have your own unique style and personality. A lot of times I'll use humor and I'll say, oh, you know what? They respond to my voice. It's not you at all. They respond to my voice. And actually, I'm pretty glad to see that your ostomy is working so well. So I know it's embarrassing for you, Try to let that go because it's not embarrassing for me and is actually a very good sign. Cultural differences are the last thing I wanted to talk about. Cultural differences can have a profound impact on my ability to communicate and teach effectively. I'm going to give a couple of different examples again. We had a young patient, he was 18 years old, he was post-pilonidal cyst resection. He had an open wound, and we were managing his wound care, so we were working with him in the outpatient clinic. But we observed that he paid no attention to us, never made eye contact, never asked questions, just looked around the room as if we weren't talking. And so we, asked his mom to come out in the hall. We're like, we feel like we're not getting through it all. And she's like, he won't listen to you because in our culture, women have no standing. And he will only listen to a male. So I'm listening to you, but he's not listening to you. And he doesn't listen to me either. So is there a male who can come and teach him? Can the doctor come teach him? Well, of course, we had to get past our feelings because we're like, what do you mean he won't listen to us just because we're female? But culturally competent care requires me to get past my own feelings, to respect the culture, that you represent, and to make accommodations in my care approach, in my teaching approach, in my communication approach. So we had to go find a male nurse who knew a fair amount about ostomy care and wound care, tell him what we wanted to cover in the discussion, and tell him if he had any questions he could come out and ask us. And of course he loved it. He didn't let us forget it for a long time. But we had to get past our own feelings. The other thing I wanted to share is something I learned from a home health nurse that I think is an extremely valuable generic approach when you're working with a patient from another culture and you might not be knowledgeable about the specific cultural differences. She was actually in Michigan, and she worked with a large number of patients from a wide variety of different cultures, some of which she understood pretty well, and others about which she knew very little. So she said what she learned to do was when she went in, she would say to the patient, I know you're from a different culture than me, and I don't want to do or say anything that is uncomfortable for you or that is offensive to you. So if there's anything I need to know, please tell me. And if I start to do something or I start to say something and it's uncomfortable, please stop me. I thought, what a great approach. One other cultural difference I'll point out, because I think a lot of us encounter this, is to realize that in some Eastern cultures and some Arab cultures, they have clean hand, dirty hand. And clean hand is for eating and social interaction. And dirty hand is for dealing with elimination. So wiping after a bowel movement, doing ostomy care. Well, think how significant that is. First of all, if I'm interacting with a person from that culture, I should never reach out my left hand. That's an insult. I should offer my right hand, regardless whether I'm right-handed or left-handed, when I meet them. Secondly, it's important to acknowledge to the patient or to ask the patient, in your culture, do you have a clean hand and a dominant, and a clean hand and a dirty hand? And if so, let's talk about how we get past that with ostomy care. For example, I can provide you with gloves. If you routinely wear gloves to do ostomy care and then you take off the gloves, discard the gloves, and wash your hands, is that acceptable? Or are there other modifications we need to make? So being respectful and then working with the patient to determine how care might need to be modified so that it does not violate any cultural beliefs. And then finally, the guidelines across the board for effective communication. I think you've heard this over and over, so I'll try not to say it, but this last time, is listen to what that person's saying to me and observe their nonverbals. If there's something that I'm not sure about, I should seek clarification. I should say, I'm not sure what you meant by this. Could you tell me a little bit more? Or are you saying this? So seeking clarification and then validating. Here's what I heard you say, am I correct? So I listen and I watch. Anything that's not clear, I seek clarification. And before I assume I know what you said, I check it out. Now, the last few things I want to go over. Supportive counseling, we talked a lot about when we talked about rehabilitative care. We talked about how important it is to hear the patient, to let the patient know that it's normal to have negative feelings, that adjustment, adaptation takes time and is a tough road, but it does get better. The farther down the road you get, for most patients, the better you feel. We talked a lot about the importance of truly hearing the patient. So our consistent strategy, whether we're talking to a patient pre-op or post-op, how are you doing? How are you doing physically? How are you doing emotionally? What questions do you have? What concerns do you have? What problems do you have? If the patient's telling me that they hate the pouch, it's too long, it's too noisy, they can see through it, it's tempting to say, I can fix that, I can fix that, I can put you in a quieter pouch, I can put you in a pouch you can't see through, etc., etc. What experts tell us is, while the patient's talking, keep your mouth shut. Let them vent, let them tell you what their issues are, what their questions are, what their problems are. When they seem to be through, ask them, is there anything else? Is there anything else we need to talk about? And then say to them, how can I help you? Would this be helpful? Would that be helpful? If there's anything I can do to help, I want to do that. I know I can't fix everything for you. If I could fix it, you wouldn't be here. And you are here. If there's anything I can do to make this walk a little bit easier for you, I will do it. Sometimes patients will say, you know what, I just needed to get it off my chest. There's really nothing anybody can do, I just needed to talk. I certainly can't change somebody's pathology before. I wish I could, but I can be there. I can hear them. I can be a sounding board for them. I can let them cry if they need to cry. I can let them swear if they need to swear. I can let them do whatever they need to do. And I can hear them. That is, in and of itself, a very important intervention. Finally, I wanted to talk very briefly about 3 very common problems that we encounter in the ostomy patient population. What we see in patients who are dealing with these problems and what we can offer these patients. So the first is depression, and of course depression is very understandable in a new ostomy patient. This is life-changing surgery, body-altering surgery, and we have to always factor in, why was the surgery done? Was the surgery done for cancer? Was this a palliative procedure for cancer? Was it a potentially curative procedure for cancer, but we don't have the results back yet? What else is going on? It's important for me to screen the patient for indicators of depression. I would never want to miss clinical depression and fail to get a patient the help they need. So every time we see them, we're asking, how are you doing? How are you doing physically? How are you doing emotionally? When you look at how you're doing this week and how you were doing last week, is this week better? Is it the same? Is it worse? If you have any reason at all to suspect depression, there are 2 very important screening questions, and they're on the slide. First of all, If you look at the last 2 weeks, how often have you felt depressed, sad, down in the dumps, blue? And secondly, if you look at the last 2 weeks, how interested have you been in doing things, going places, accomplishing things? And if the patient says, well, yeah, I have my ups and downs. So sometimes, like yesterday, all of a sudden I just was on a crying jag, and it lasted about 20 minutes. But then the rest of the day I was pretty good. And I don't think I've had as many crying jags this week as I did last week. So I guess I'm getting better. And then I ask you about, well, what about, if you look at the last 2 weeks again, are you interested in doing things, going places? Well, yeah, I'm starting to think more about, oh, I'd like to do this, or I'd like to go there, and I'm making myself get out a little bit. It's hard, though. I'm really nervous. Okay, that's all very normal. But if a patient says, you know what, I could cry any minute, any hour of the day. I feel like crying all the time. Even if I'm not crying, that's what I feel like doing. And you know what, there's nothing I want to do. What I really want to do is I just want to curl up in bed. And sometimes I just want to curl up in bed and die. Okay, now I have clear-cut indicators of clinical depression. So start with general screening. How are you doing physically? How are you doing emotionally? How do you think you're doing this week compared to last week? You pick up any indicators of depression, ask these 2 specific screening questions. If the patient sounds clinically depressed, then you want to say, do you ever have thoughts of hurting yourself? Do you ever have thoughts of suicide? And you are going to do an immediate referral for any patient who has thoughts of suicide, of hurting themselves. You are going to do a referral. It doesn't have to be stat, it should be urgent for any patient with clinical depression. And what you want to say to the patient is, you know, I'm really concerned about you because it sounds as if you have something that we call clinical depression, which is not uncommon after the surgery. There's so much on your plate, so much going on. It can literally change the chemical balance in your brain, and that can cause a lot of these very, very sad feelings that you're having. So I'm going to refer you to Dr. So-and-so. I want you to get further evaluation. Sometimes people need short-term medication to correct that chemical imbalance and get them back on track. Because this isn't, I would like you to consider this referral. This is a referral that really needs to be made. For suicidal thoughts, you literally make a stat consult. What if I have a patient who kind of has those ups and downs, or what if I have a patient with signs of clinical depression? I have referred them, they're going to be seen. Is there anything I can do? Yes, there's things I can do. I can say, well, let's talk about some things that might help you a little bit. First of all, I know sometimes it probably feels like you'll never get past this, and there's just so much to learn and so much to do, and you hate everything. So let's try to break it down, and let's set some small goals. I want you to be able to see that you're making progress. So let's make some goals for this week. You're already doing a really good job of taking care of yourself. So in my mind, that's already a very important goal that you've met. I don't know if you're even giving yourself credit for that, but you should. So what about for this week, we make some specific goals about you getting out of the house. Maybe not for long, but just getting out of the house so that you can see, okay, I'm taking those baby steps to get better. Even when you feel awful, baby steps can help. Can help you see that, okay, maybe I can get back into my life. Also, I want you to, when you can, I want you to challenge some of the thoughts you're having. For example, if I heard you say, nobody will ever want to have sex with me again, I want you to stand back, and whenever that thought goes through your head, I want you to think, really? Is that true? That no one will ever want to have sex with me again? That's probably not true. If I'm a female and I'm saying no male will ever want to have sex with me again, I must not know very much about men, because most of them are pretty open to sex most of the time. So challenge those negative thoughts, set small goals. That helps every patient. And then for any patient with signs of clinical depression, they get a psych referral. Any patient with suicidal thoughts gets an urgent, immediate psych consult. Also, we've talked about the importance of hooking them up with peer groups like the United Ostomy Association of America. Again, what's the message? You're not alone. There are people who will share their tips. There are people who have walked this path before you and will be glad to turn around and give you a hand. The second problem I want to talk about is anxiety. And it's usually pretty easy to tell when somebody's anxious. They'll verbalize. They'll say, I worry, I just can't think about anything else. I'm worried about this all the time. This thing is just taking over my life. Okay, well, tell me more about it. Well, even when I'm trying to do something else, I'm worried that the pouch is going to come off. I'm worried it's going to come loose. I'm constantly checking it. I'm constantly feeling it. I'm constantly going to the bathroom. I can't enjoy anything. I can't do anything. Even sitting on the couch watching TV, I'm worried about my pouch. I'm just obsessed with this stupid pouch. If you're not sure, you're picking up less obvious indicators. And less obvious indicators, you might be like, so how are you doing physically? I think I'm doing okay, I guess. Yeah, I guess I'm doing okay. My pain's better, and I guess my appetite's a little better. So, yeah, my doctor says I'm doing okay physically. Okay, so how are you doing emotionally? I don't know. I guess I'm okay. So, do you feel depressed a lot? No, not really depressed. Worried. I worry a lot. That's what it is. I'm worried. Okay, so can you tell me more about that? Well, wouldn't anybody be worried? Wouldn't they be worried that this thing's not going to stay on? I just can't see how I'm ever going to get my life back with this thing. So, whatever pathway you use to identify the fact that this patient's dealing with a lot of anxiety, you want to summarize by saying, so, let me be sure I understand what's going on correctly. And, first of all, I have to tell you, this is a pretty common problem, so I don't want you to feel like you're the only one this has happened to. This is pretty common. But it seems to me as if you're so worried that something bad is going to happen that it's kind of paralyzing you and keeping you from moving forward in the way you would like to move forward. I know you talked about in the hospital some of your goals, or to get back to work, get back into your life. What I'm hearing from you today is that the worry about the pouch or whether it's going to stay on or come loose is kind of keeping you from making the steps, taking the steps you need to take to meet those goals. Is that right? Am I understanding correctly or not? And they're like, yes, that's exactly what's going on. And I don't know how to get past it. Then here's what you can do. You can say, here's what I want to start with. I want to start with how you would handle the worst case scenario. And here's why I want to start there. I think if you're prepared to deal with worst case scenario, you're prepared to deal with anything. So let's talk about what you would do if you were out shopping and all of a sudden you could feel that your pouch was a little bit loose and something seeping underneath the tape and the barrier. What would you do? How would you handle that? Do you have a plan? So we're going to go through, well, I have an emergency kit. I would go to the bathroom. I would do this. I would do this. I would do this. What would you do if you were at work and your pouch started to become loose? What would you do if you were in a meeting and your pouch started to become loose? Well, what do people do when they're in a meeting and all of a sudden they feel ill, or all of a sudden they have to go? They're like, excuse me, and they go to the bathroom. That's what you're going to do. So you help them plan for worst case. a lot of times that brings the anxiety down, brings the worry down. Then you can say, okay, now I want to talk about another thing. When you get into these cycles of worry, what usually helps you? What helps you break out of that cycle? Well, sometimes it helps me if I just get up and go do something. Or sometimes it helps me if I just call a friend so that I'm forced to think about something else. Okay, well, let's think about some things you can do. You're already prepared to deal with worst case. You know that I'm here to help you should you start to have problems with your pouch. Right now it's doing fine, but I'm here to help you if you start having problems. So you know how you're going to deal with that. Now let's think about what you're going to do when you find yourself going through this cycle. And let's talk about this. We want you to be able to start taking those steps toward meeting your goals. So you want to be pretty much back into your usual lifestyle within 6 weeks. So let's set some goals for this week. You've got your worst case plan. Let's set some goals. Now, if a patient is paralyzed by anxiety and they tell you that they're having borderline panic attacks, they need medication, so you're going to do a consult. And then finally, frustration. And I think we can all deal with this, or I think we can all understand this. When we're dealing with something new, we're not very skilled at doing it yet. We don't feel very good anyway. We don't even want to be dealing with this problem. And we're frustrated, easily frustrated. I'm going to tell you about a severe case of frustration. I had an ostomy patient who said she got so frustrated dealing with a leaking pouch that she finally just took off the pouch, put on Depends, and went to bed. Because she's like, I can't deal with it anymore. I was so mad, I could have just, if it would have done any good, I'd have slapped that stoma. I'm like, okay, I get it. That didn't work very well for you, and so we're going to talk about what to do next time, but I totally get where you were coming from. And that's what your patient, that's very helpful when you get where your patient's coming from. So if your patient's like, I'm just mad all the time, this thing irritates the heck out of me, I can't see how anybody ever gets used to these stupid things, you're like, okay, tell me what's making you crazy about this. Well, I hate this dadgum clip. It gets caught in everything and blah, 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 blah. And it seems to me like it shows through my clothing. So I'm always worried about, is anybody looking at me, staring at that thing? And then yesterday, usually if you give them a chance to talk, they'll talk. And then yesterday, I was ready to leave the house to go run some errands, and the stupid thing starts leaking. Here I am on the way out the door. Then I have to go back to the bathroom. I have to take the whole stupid thing off, start all over again, trying to get the pouch on. I was so mad. Okay? You know what? That is totally normal. I totally understand that. Everyone who has walked this path before you would tell you they understand that. Because it is frustrating when you think you've got your pouch on and it comes loose and you have to go change it and it doesn't fit your schedule. You're supposed to be somewhere. And those little things can make you crazy. Is there anything else that's just driving you crazy about this thing? No, that's pretty much it, I guess, for right now. It's like, okay, there may be other things as you walk down the road. This is a really hard time. You're trying to learn a bunch of new stuff. You're trying to learn things you never wanted to know. You certainly never wanted to need to know this. So your frustration, your anger, all of that's totally normal. So first of all, just give yourself permission. You can fuss at the stoma, you can cuss at the stoma, you can scream at the stoma, you can do whatever you need. You can name the stoma and talk about it badly, if that helps at all. I can tell you that everything you're doing is right. You're doing a good job of learning what you need to learn and dealing with each situation as it comes up. So I want you to, number one, give yourself credit for the fact that you're actually coping extremely well with a very difficult situation. I want you to give yourself permission to be really ticked off When you need to be ticked off, that's fine. And let's talk about some things we might be able to make a little bit better. Last thing, when do we refer? And I think we've kind of covered this. Anytime a patient gets stuck and is not making progress, you want to suggest professional counseling. That's what they do. They're very good at it. So you want to have a list of counselors, and you want to compile that list by talking to other patients or other clinicians who can say, yes, this person's a very good counselor, and particularly good for patients who are dealing with changes in body image, having to learn new skills, just dealing with multiple things on their plate at one time. And of course, any patient with clinical depression, severe anxiety, or suicidal thoughts. And UOAA, one last plug. Okay, that's it for this session. Thank you very much.